Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
First of all, thank you everybody for sort of allowing me to join this online symposium forum that we have through the LE&RN setup. My name is Dr. Christopher Smith. I'm one of the lymphatic interventionalists here at the Children's Hospital of Philadelphia. I'm trained as a pediatric interventional cardiologist and have had special training additionally with Dr. Yoav Dori here as an interventional lymphologist as well. I'm an assistant professor here at the Children's Hospital of Philadelphia and a member of the Jill and Mark Fishman Center for Lymphatic Disorders. Today, I'm going to talk to you about some of the new diagnostic procedures and interventions that we have available for treating patients with systemic lymphatic diseases, as well as the new ideas that we're having about how these disease processes are actually developing and occurring. So before we sort of get started, I have no disclosures to disclose. We will talk about towards the end of the talk a couple of off-label uses of medications. There are currently, unfortunately, no FDA-approved medications to treat a lot of the systemic lymphatic disease processes that are actually occurring, but we will have some intriguing information with some of the medications that are available for an off-label use. So what exactly is the lymphatic system? So the lymphatic system is a part of our circulatory system. It plays very key roles in multiple aspects of our everyday life that we sometimes kind of take for granted. It has a very important role in the defense against pathogens and infections. It's a key mediator in the immune system that allows us to fight these different agents. It also plays very important roles in transmitting nutrients throughout the body, in particular fatty acids, macromolecules, and proteins, particularly from our diet, so they can actually get distributed to where they need to go. One of the most important functions, however, of the lymphatic system is actually is clearly a critical component of our circulatory system, with the arteries and the veins delivering all of the oxygen and nutrients that we need to function and to survive. As a part of that process, there's always a small amount of fluid that gets deposited into our organs as well that has to be removed somehow, otherwise they would be continually get fluid overloaded. And so one of the very important functions it serves is to actually remove that extra fluid and take it back into the circulatory system so it can continue to distribute all the nutrients that need to be distributed throughout the body. And the way that it does this is through a series of lymphatic blood vessels or lymphatic vessels. Here is just a basic overall anatomy and view of what the lymphatic system looks like. There are three main components that contribute to lymphatic flow throughout the entirety of the system. And those originate from the peripheral lymphatics, denoted here as lymphatics that would be coming from the legs. There's also lymphatics that come from our liver, as well as lymphatics that come from our mesentery or intestinal lymphatics. The combination of these three streams of flow or contributors of lymphatic fluid is about 95% of the lymphatic fluid that actually flows through the body. And in the abdomen, these organs all coalesce in a structure here in the center called the cisterna chyli. And from there, the lymphatic fluid flows through the main highway of the lymphatic system called the thoracic duct. It originates in the upper portion of the abdomen and continues through the thorax and ultimately connects back into the venous circulation, as I mentioned before, typically up here at the left portion of the neck. Along the way, it picks up other lymphatics from the organs in the chest, including the heart and the lungs as well. Now, there are a lot of factors that can actually influence this very complex system. The lymphatic flow itself is a very fine balance between how much fluid is actually being produced and how much fluid can actually get distributed back into the circulatory system itself. There are a lot of factors that can influence that. We're not going to go through all of them here, but suffice to say there's quite a few variations that can actually influence the overall flow through the lymphatic system. Both things that we can control and then things that we can't control. There are also lots of different medications. They both have positive and negative effects with lymphatic disease, lymphatic function. And there are other types of modifiers that we see, in particular our diet, which can significantly impact how much fluid is actually being produced in the lymphatic system and needs to find locations to go. So what do we see in the context of lymphatic disease? Well, lymphatic disease and sort of lymphatic dysfunction from a clinical standpoint usually manifests in the inability of the lymphatic system to do its job. And as I mentioned before, its main job is to actually remove interstitial fluid, or this extra water that's deposited in the tissues during normal circulation. And when the lymphatic system can't do that anymore, the fluid starts to build up. And we see that manifested clinically as a number of different disease states, anywhere from lymphedema, which is primarily fluid collection in an extremity. It can also occur in the skin and cause generalized edema or anasarca. We can also see fluid accumulating in various compartments that we call them, which are essentially the chest and the abdomen, either as pleural effusions or plastic bronchitis or fluid around the heart. And you can also get fluid in the abdomen called ascites, as well as fluid that actually accumulates with the intestines themselves called protein-losing enteropathy. Now, a lot of these manifestations that we see of lymphatic dysfunction have several different etiologies. But one of the underlying mechanisms for why we see those things develop is because there's abnormalities in flow. As I showed you the patterning of the lymphatic system just previously, we know that there are lots of different ways to affect the flow that can actually affect the development of these manifestations of lymphatic dysfunction. That can range from simply thinking as far as leaks within the lymphatic system. So if there's a trauma to a vessel and it's just continually leaking the fluid that it should normally be transmitting along, that can cause fluid accumulation. But more typically, what we see as a manifestation of systemic lymphatic diseases is the fact that there's a combination between the lymphatic fluid that should be produced and its ability to get to where it needs to go. And if there's what we call conduction abnormalities, where the lymphatic vessels are not patterned necessarily the correct direction, or if their flow is reversed or flowing in abnormal ways, we can see a combination of these two leading to what we call perfusion abnormalities. And these perfusion abnormalities are actually what ultimately results in the abnormal collection of fluid in those various areas, such as around the heart, causing chylopericardium, or in the abdomen, causing ascites and PLE, other areas in the chest with chylothorax. So anywhere you can basically imagine fluid can collect, it does. And it's also important to note here that it's not just individual compartments. One person can actually manifest as a part of their disease an accumulation in all of these compartments, or just a single compartment. So the sort of underlying key for us to really understand a lot of how these flow disorders work, we have to be able to visualize the system. But with the knowledge that we do have, we can kind of just devise how the system is being perturbed in such a way that we see these malperfusion abnormalities. And we can grossly define these as basically between primary and secondary causes. So primary causes, I know you've heard a lot through the Symposium series here, are disorders that are mainly generalized lymphatic maldevelopment, such as Kaposiform lymphangiomatosis, GLA, Gorham-Stout, and other types of genetic syndromes that are known to have maldevelopment of the lymphatic system, such as Noonan syndrome and Turner syndrome. This is one component of why we see abnormal flow patterns and these flow disorders in these patients. But there's also a whole group of secondary effects that's actually probably much larger than the primary effects. And we see quite often as well in the world of pediatric cardiology in the context of heart failure and congenital heart disease. I'm not going to talk much about those contributions today, but there are other causes of secondary failure, such as infection and radiation, as well as any other aspects of obstructing the lymphatic system, either at the outlets or anywhere along its path that it's continuing. They can have cause some of these conduction abnormalities that ultimately lead to the perfusion going into the wrong directions. So as I alluded to just a minute ago, one of the key ways that we are able to diagnose these and understand how the system is actually causing the manifestations of lymphatic disease is we have to be able to see it. There are numerous ways to visualize the lymphatic system. I'm only going to talk about one today because it's predominantly the most sensitive and it gives us sort of the most information of what the lymphatic system is doing. And this is using an MRI-based technique. The original description of some of the MRI-based imaging used what we call heavily weighted T2 sequences, which allow us to show us basically a static picture of lymphatic fluid that is collecting in various locations. Now, the problem with this particular imaging modality, as I just alluded to, is that it's actually static. So it only gives you one picture in time, and it really only tells you where there is currently fluid. It doesn't tell you how that fluid is getting there or what the architecture of the system actually looks like to actually give you the abnormal fluid collections that you're seeing. So we use an adjunct to that called the dynamic contrast MR lymphangiography. And this is where you can specifically inject MRI-based contrast into the lymphatic system to actually see how the fluid is flowing. And this is very important to sort of really gauge and understand what is underlying the manifestations of lymphatic failure. Now, here at the Children's Hospital of Philadelphia, we've used 3 different imaging compartments or imaging modalities. And as I mentioned before, you know, the main contributors to lymphatic flow are the peripheral lymphatics, the liver lymphatics, and the mesenteric lymphatics or the intestinal lymphatics. Now, these different compartments, again, comprise most of the flow that goes through the lymphatic system. And so it's very important for us to understand how these different compartments interact with each other and how they can cause disease. So under ultrasound-based imaging techniques, we're able to localize these structures and place small needles into these various structures and inject that contrast just like you saw in that image before. And as an example, each one of these compartments gives us a different series of information. And so from the intranodal injection, this can also be thought of sort of a continuation of what happens from your peripheral lymphatics, from all the way down in your toes through your legs, and ultimately coalesces in the inguinal regions where there's a series of lymph nodes that then progress and connect into the central lymphatic system itself here up to the cisterna chyli and ultimately to the thoracic duct. This technique is very good at imaging the essential central components of the lymphatic system. The second type of imaging technique we use is intrahepatic dynamic contrast MR lymphangiography. And again, the liver has a series of ways that it can contribute to the lymphatic flow. The majority of the flow leaves the liver hilum and connects to a few series of lymph nodes around the pancreas and the aorta, and ultimately has connections to, again, the central lymphatic system here, the cisterna chyli, and up through the thoracic duct. And on the right, you can see a representative image of how this looks on MR lymphangiography with a normal connection to the central lymphatic system. Now, the last imaging modality, probably the newest imaging modality that we have, is a ability to image the intestinal lymphatics. This has been a very elusive compartment to actually image, and recently Dr. Dory made advances in us being able to access some of the lymphatic structures around the intestines themselves, and in a similar fashion inject the MRI contrast, which allows us to, again, follow the paths of flow from these organs into the central lymphatic system. One of the other imaging modalities that we use is also an ultrasound contrast-based technique. This is extremely important when we're looking at some of the etiologies for lymphatic dysfunction, including those that may have actually obstructed lymphatic systems or may not actually connect back to the venous system. As you can imagine, the treatment options for that is quite different. So with this imaging modality, we inject the ultrasound contrast in the lymphatic system, either in the intranodal, in any of the access sites that I just mentioned before. And with ultrasound, we visualize up where it should connect into the venous circulation. And here you can see with these bright bubbles that this particular patient had quite a wide connection to the system. Now, we also have other more direct and more invasive ways to look at the lymphatic system, and typically we combine these with planned interventions, which we'll discuss in a little bit. This has to do with direct access of the lymphatic structures themselves. With the needles and small micro wires and microcatheters, we're actually able to directly access some of the larger central lymphatic vessels. That allows us to, in a more controlled and potentially intervenable environment, actually opacify the abnormal flow patterns that we may be seeing causing their underlying disease. So those are some of the basic techniques that we use to be able to see the lymphatic system. Now, some of the treatments that we can offer, I'll talk about a couple of them here, and then we'll go through several series of examples, and you can see some of these different treatments in action. So from a lymphatic treatment standpoint, when you have an area that has multiple areas that are leaking or having these abnormal perfusions that are leading to the disease, the manifestations of the disease that we see, there's a few different ways to treat them. There's an interventional based approach, which traditionally has been for the disorders in the chest, doing a full thoracic duct embolization, which is a way to basically stop all the lymphatic flow from going into the chest, thus preventing it from actually making it to these abnormal directions towards the organs that are affected. This was a great modality, and it improved outcomes in a lot of patients, but it's also in patients who have areas that are leaking in multiple locations. You can imagine if you stop one way that's essentially the normal way, you can actually potentially make the other areas worse. And so this led to the development and a more selective ability to actually engage only those lymphatics that are causing the problems, thereby leaving the normal system intact so it can continue to function as it was designed to. There's also other advanced interventional techniques that we're not going to talk about, but actually aim at trying to change some of the physiology of the lymphatic system itself. There are also several surgical-based techniques, such as lymphovenous anastomoses, which we typically see in patients who have the distal portion of the duct not actually connect to the vein. And so we're able to actually, with our surgical colleagues, recreate that connection and actually alleviate a lot of their disease. There's also other types of surgical procedures such as pleurectomy and pleurodesis, which we'll talk about just shortly. And then finally, as another component of the treatment strategies are medical-based therapies. A lot of the patients that we see do have secondary types of causes of lymphatic dysfunction, and so their treatments are tailored more to addressing why they have these secondary manifestations. A lot of the primary disorders, there are some medications that are available, in combination with interventional-based techniques, we're able to sort of affect improve the quality of life, improve the abnormal fluid collections that may be causing a lot of symptoms and a lot of problems. And as we'll talk about towards the end, there's also a lot of new and exciting information about the lymphatic-specific drug therapies that actually be able to help modify the lymphatic system, either in combination or in isolation of other interventional strategies. So the first area I want to sort of discuss deals with disorders of the lymphatic flow within the chest itself. Now, the areas that I sort of have mentioned before, these occur whenever there's fluid that accumulates around the lung, and that would be chylothorax. It can accumulate around the heart, which is what we call a chylopericardium. And if the connections to that are causing the abnormal fluid flow actually connect to the airway themselves, this can cause the fluid to accumulate there, and it produces something called plastic bronchitis, which I'll show you pictures of shortly. The reason why I wanted to start here and why this is quite a important area to understand, particularly in those with some of the primary lymphatic disorders, is the fact that it greatly is associated with changes in outcomes. So some work done by Dr. Trenner has shown that in some of the general lymphatic disorders such as Gorham-Stout and GLA, that when you have development of effusions or abnormal fluid collections in these different areas, this greatly impacts your survival percentage. And it reduces it significantly compared to those who don't have any collection of any effusions. And so understanding not only from a basic physiology standpoint why some people develop effusions and other people don't is crucial in kind of understanding why the increase or to sort of decrease in survival, as well as can we modify this? Is there a way that we can change that so that we can change somebody who has effusions to not having effusions? So as I mentioned, the first step to a lot of this is imaging. And so with a lot of these generalized disorders, we have imaged many different patients with these different techniques. And I'll go through a few examples here just to show you sort of the pleomorphic effects of the actual disease and how big of a spectrum you can actually see. So this is a patient with KLA who presents with essentially mediastinal thickening, which is a hallmark of the disease. You can see significant pulmonary sort of perfusion around the airways and the mediastinum, as well as the pulmonary edema and a collection of fluid up in the neck regions as well. And when you do the intranodal lymphangiogram, you can see that the lymphatic system itself is also not normal. It is very dilated. The thoracic duct is quite tortuous. It doesn't have that nice straight line. And then, of course, the big finding here is that all of this edema that we're seeing here correlates with the perfusion from the central lymphatic system into these areas that are showing edema. Now, another patient with KLA, very sort of similar findings with the mediastinal thickening. This patient also has accumulation within their abdomen with ascites, a lot more skin edema, as you can see here in these regions as well, in addition to all of the pathology that we see into the chest. And even though they also have KLA, you can see that the lymphatic system looks different in this patient. So not in every KLA patient do the systems look the same. And in fact, here's another example where this is sort of on the less severe spectrum, at least in the terms of edema and fluid collection. There's still the mediastinal edema and thickening that we can see here with the pleural effusion. Not so much in the skin, but when you look at the central lymphatic system, it actually appears to be relatively normal. So it's unclear, again, the true contributions of some of these different compartments on how the variation in the disease processes that we see. But there is some element in other patients that we can actually intervene on in these disease states. And here's an example of a patient who has GLA and had a chylothorax. So these would be one of the patients that are extreme risk for decreased survival because of their underlying disease. And here on the left, you can see an MRI image with the significant pleural effusions and a very small amount of lung tissue that's actually functional. You also see the hallmarks of the cystic lesions within the bone, as well as in the spleen, as you can see here. And on the right, this is a fluoroscopy image watching essentially the patient breathe. And you can see that the lung tissue here, there's not much lung that's actually able to help oxygenate and help function. So you can imagine that this is not going to confer a lot of survivability. It might actually cause a significant amount of symptoms. So with our imaging-based techniques, we're able to elucidate why in the world does this patient have this massive chylothorax. And with imaging the central lymphatic system, we can see significant perfusion abnormalities. There's a lot of perfusion that goes along the ribs themselves into the lung tissue, and then also traverses across the middle of the chest and over to the right side, which is, again, the etiology of why this patient has the chylothorax. So in this sort of diffuse disease process, what can we actually do to treat this? And because it's so diffuse, we work very closely with our general surgery colleagues. And because of the chronicity of these effusions, a lot of times the lungs themselves, even if you take the fluid out, they can't expand. So you have to kind of help remove a lot of the thickened areas of the lung that help it expand so it can actually function better. And so with our general surgery colleagues, we do what's called a thoracotomy. So we are able to open and expose the pleural space. The surgeons are able to remove the excess thickened pleural space. And then because we can directly visualize where these abnormal lymphatic channels are, we're able to selectively glue embolize a lot of those areas that had actual weeping and leaking of this fluid. And as you can see in this particular patient, this actually resulted in almost complete resolution of their pleural effusions, as well as you can see the lung is now actually completely expanded and fills the entire thorax. So this is one way and sort of one methodology that going from imaging, devising a treatment that we can actually hopefully impact some of the poor outcomes that are typically associated with these diseases. Now, another disease state outside of chylothorax that still involves the chest is something called plastic bronchitis. Now, this disease, as I mentioned before, occurs when those connections, instead of going into the lung tissue itself, actually makes connections to the airway. And what happens is, with the image on the right, you can see in a patient with the plastic bronchitis and a bronchoscope down the airway, with injection of a blue dye into the lymphatic system, you can see how engorged and prolific the lymphatics are of these airways. which when they start to leak can lead to the protein deposition and ultimately the cast formation that you see on the right, which basically gives you a picture of what the airways in your lung look like. Now, the traditional treatment strategies for a lot of plastic bronchitis has been using a full thoracic duct embolization. This is typically done with coils and other embolization agents, such as Trufil and Histocril, that are agents that are essentially medical grade superglue that allow us to prevent flow from going any further through this. But we found that, again, that in patients who have other signs of lymphatic disease, taking out the normal pathway can actually make those disease states worse. And so what we favor doing in a lot of our patients now is actually something called selective lymphatic duct embolization, as I alluded to earlier. And this is a patient with plastic bronchitis that has abnormal perfusion, you can see here to the right lung, with significant perfusion abnormalities that was actually causing his plastic bronchitis. And when we access the lymphatic system and directly and inject contrast, we can actually see that the thoracic duct actually has two connections. One goes up to the vein that you can see here. And the other one is a very large branch that actually continues on and is the primary source for the flow that's actually going to the lung. So we're able to selectively engage only this collateral that's actually causing the abnormal pulmonary perfusion and embolize that with the agents that I mentioned before. And in the end, what we end up with is a thoracic duct that is still open. And in this patient, it also turns out there was a second duct that was going to the right that we also were able to keep intact by only embolizing the distal connections that were causing the abnormal perfusion. So this is a technique that we more and more commonly prefer so we don't cause other perturbations in the lymphatic system and potentially cause other problems. So in patients with plastic bronchitis, the outcomes are really good. So we had patients in some of our series of data here where we have about 70 patients that have a pretty frequent symptoms of coughing up these airway casts. And when you treat them, you actually found that more than 80% of the patients have resolution of their symptoms, with more than half of them having complete resolution almost immediately. This is fantastic because it completely modifies the disease process that typically continues to happen if we're not able to stop these casts from forming. The interesting component of this, though, is that there's still about 19 to 20% of the patients that didn't completely respond. And what we found when we began to look at why there are some patients that didn't respond, we came across a whole new area of plastic bronchitis and under our understanding of where these abnormal connections are coming from. If it's not from the thoracic duct, then where is it coming from? And so with further evaluations of the other lymphatic streams of flow that I mentioned before, we actually found that the liver itself, while it has normal connections to the central lymphatic system, can actually grow and make its own connections that will perfuse the lungs and cause the same symptoms of chylothorax and plastic bronchitis. And as an example, in a patient here with an intranodal injection, you can actually see that the central lymphatic system does not show any evidence of pulmonary perfusion. The duct courses off to the right, which is can be a normal variant, but there's otherwise no perfusion of the lungs. But on further evaluation of the liver lymphatics under fluoroscopy, we actually found that there was large connections that were perfusing up towards the mediastinum, towards the lungs, that you can see here that was actually the etiology and the cause of this patient's plastic bronchitis. So when we look more globally, and we actually do a retrospective analysis looking at all of our patients who we've looked at their liver lymphatics, we found some interesting results. So there was approximately between 2016 and 2019, there were about 105 patients that had liver lymphatic imaging as a part of their evaluation here. They across a significant amount of the types of diseases we see, including chylothorax, ascites, plastic bronchitis, and PLE. And what we identified as we reviewed their imaging was that there's actually a significant pattern of lymphatic flow that we can identify. And we, in addition to the normal patterning, we actually found 4 additional abnormal patterns that I'll show you correlate with their disease states. So we know what the normal looks like, as I've showed that a few times, the connections to the cisterna chyli and up to the thoracic duct. But then we identified a group called hepatoperitoneal, which is abnormal connections from the liver lymphatics as they exit the liver that actually leads to direct accumulation of fluid within the abdomen. We see this, this has been seen before in other instances of chylosocietes, but we were able to identify it, see it both by MR lymphangiography as well as, again, under direct lymphangiography that was not previously seen before in a lot of these patients. Next one is the hepatopulmonary, which I already showed you an example of, but there are numerous examples where the liver lymphatics have abnormal connections, usually through the capsule or the top of the liver. They can actually go directly into the lungs themselves, as you can see here, with significant perfusion of the lungs that ultimately cause these abnormalities. There's a hepatomesentery, which we don't necessarily think is due to abnormal connection or abnormal growth of vessels, but it's essentially a sign that the flow is going the wrong direction. Normally, everything should go towards the central lymphatic system, but with a hepatomesentery, when you inject the liver, you see the mesentery light up. So there are some flow abnormalities that are actually allowing the flow to go backwards against where it normally should be flowing. And then finally, the last category was the hepatoduodenal connections, which have been seen and reported before in patients with a disease called protein-losing enteropathy. And this group of patients results in their disease with the connections from the liver bypassing or creating abnormal connections back to the intestines rather than to the normal central lymphatic system, or they can have both. So these categories, when we looked at the different types of imaging categories of these connections and the underlying disease presentations, we found that there was significant correlation between the patients with hepatoperitoneal findings and ascites and chylothorax, as well as hepatopulmonary findings, as you can imagine, with chylothorax and plastic bronchitis, since those are intrathoracic abnormalities. And then a very, very strong association with the hepatoduodenal connections and protein-losing enteropathy. So what we have been able to do using these new imaging modalities, particularly this intrahepatic lymphangiography, it gives us a greater understanding of how the process of PLE is the pathology behind what's actually occurring. And here's an example of a patient who has quite significant PLE with significant perfusion of the duodenum that you can see here. There's actually so much perfusion that it actually refluxes back into the stomach. Now, in addition to these abnormal connections, you do still see that the central lymphatic system does opacify. So there are not only abnormal, but there are also normal connections from the liver lymphatics in this entire process. It's not that the entirety of the liver is abnormal. When you look at a slightly delayed image, you can see that there's quite significant perfusion in this patient of the intestines, with continued perfusion of distally as well as even further reflux back into the esophagus. But again, there's still opacification of the central lymphatic system. So going along with the idea of being able to selectively embolize only the abnormal connections so we can allow the liver to still drain normally is one of the keys to underlying and treating this disease. And one of the ways that we do that is with our gastroenterology colleagues who are able to place an endoscope into the proximal portion of the duodenum. And when we have access to the various lymphatics that are perfusing these areas, we actually confirm with methylene blue dye injection, just like we did for the plastic bronchitis I showed you earlier, that there are connections to the intestines. We also, with under fluoroscopy, make sure that there's no further connections to the central lymphatic system as well, and we're only trying to embolize the ones that are causing the abnormalities. And what this looks like under fluoroscopy during the procedure itself is an image here on the left. With injection of our embolic agents, such as the histocril, as I mentioned here, or I mentioned earlier, we're able to see significant filling of lymphatic vessels and lymphatic channels, but then almost immediately you see after this channel fills, there's these blobs of glue that are actually forming. Those are actually within the lumen of the intestine, and with flushing from our endoscope, we can actually break up that glue and flush it forward, but just proving that there's connections from these lymphatics into these intestines. And as a part of this disease process, with losing a lot of lymphatic fluid in their intestines, they have a lot of electrolyte and nutritional deficiencies. And one of the markers of this that we use commonly is albumin. Albumin is highly produced by the liver, and it helps us to maintain that there is no, to help control basically our fluid status, as well as a marker of our nutritional status. And in all of the patients that we've treated, we see variations, but an overall significant trend towards improvement in not only their albumin, but also self-reported symptoms. When we take a step back and we look again at our whole cohort that had abnormal liver lymphatics, we did find that regardless of what your presenting type was, either ascites, PLE, plastic bronchitis, chylothorax, if you had abnormal liver lymphatics, you had a decreased likelihood of complete resolution of your symptoms. So basically what that sort of boils down to is if you had abnormal liver lymphatics, you're likely to still have some element of disease. That's partially, I think, at the time, not completely understanding how to treat these different diseases, which has clearly changed over the course of the last couple of years. That typically meant that you also needed more interventions than if you had normal liver lymphatics. But regardless of needing more interventions or a longer time for your symptoms to resolve, there was actually no difference in morbidity or mortality, which is reassuring, but also helps us to know what we need to do in order to treat these underlying diseases. So, similarly with the discovery of these liver lymphatics and liver connections, as I mentioned, we do multi-compartment analysis now. And just like we saw with the plastic bronchitis and chylothorax, there's a subset of those with protein-losing enteropathy that actually do not have the typical hepatoduodenal connections. And so, every time you create a new imaging modality, you can see more and you find more, but it also brings up more questions. And so to sort of round out some of the findings that we found is that in this some of these particular patients, we found an additional source of protein-losing enteropathy, which was not necessarily known before. Here's a patient with a congenital lymphatic anomaly, conducting anomaly, who has protein-losing enteropathy. His intranodal injection essentially showed a relatively benign central lymphatic system. However, with the intrahepatic injection, we actually see that it doesn't connect to that same central system. It actually goes through an entirely different system through a right-sided lymphatic duct up to the right venous angle, but also does not perfuse the duodenum. So it has abnormal connections that are still connecting normally back to the venous circulation, but isn't actually the cause of why there was clinical protein-losing enteropathy. And it wasn't until Dr. Dorey had developed these intramesenteric imaging that actually allowed us to identify that the reason why this patient was having PLE was because the intestinal lymphatics themselves were draining back into the intestine, kind of creating this vicious loop or this vicious cycle, which was actually the cause of why the patient had lots of protein loss causing the protein-losing enteropathy. And so we have really identified that between these three different compartments and trying to understand the perfusion and symptoms that we see from patients with systemic lymphatic diseases, is that really imaging multiple compartments is absolutely necessary to truly understand all of the physiology that's going on. Despite the fact that you may not have symptoms of one thing, you may actually have the predisposition for developing those. And so I'll go through a couple of examples to show what we've seen, why this is very, very important. So with another 12-year-old who actually had quite severe and significant non-chylous ascites, he also had protein-losing enteropathy, and he ended up actually having a history of chylothorax as well. And as a component of, and as a side for a lot of the patients that we see with these systemic lymphatic diseases, again, it's not isolated to just one area that's causing problems. It's usually multiple areas. And so to really understand what's going on, you need to see all of the areas that could be potentially involved. And in this particular case, we were able to delineate very clearly some of the causes of his underlying disease. And from the intramesenteric injection here on the left, there's, of course, a lot of edema within the mesentery, but the arrows in the abdomen here show that there's actually small loops of bowel throughout that kind of have a little bit of perfusion, probably hinting at possible etiology of his protein-losing enteropathy. But it does still connect normally to the central lymphatic system, and through the thoracic duct, we're actually able to see that there is some pulmonary perfusion as well, probably explaining his history of chylothorax. The intrahepatic imaging was actually quite different. And in this particular case, we saw that there was a huge collection of contrast within the peritoneum, actually as the origin of what was causing his ascites. In addition to that, I think you can tell here that there's more perfusion you can see up here in the chest than we could see with just the intramesenteric injection, also showing us that there's abnormal connections from the liver to the lungs as well. And with the intranodal injection, we don't see any of this. We really see that there's a dilated retroperitoneal lymphatics, but otherwise the central duct looks very similar in opacification to what the intramesenteric did. So what this allowed us to do, of course, since we now have localized where the leak was actually occurring, is using the ultrasound-based techniques that I mentioned before, are actually able to localize where the leak is actually occurring as it exits the liver, target that directly, and glue embolize those connections. And so here, this is an embolization of here, the exact area that was causing the leak in this patient's non-chylous ascites, and actually resulted in the complete resolution of his symptoms. Another example of multi-compartment imaging affecting our diagnosis is an 11-month-old who was diagnosed with GLA, PLE, and ascites. So in this particular case, you can see that on the left here that there's a lot of fluid within the abdomen consistent with his ascites. There's also small amounts of pleural effusions here. But you can also see that there's quite a large lymphatic malformation here in the thorax or in the chest. With the intramesenteric injection, we can actually see that the mesentery itself actually just pools there. It doesn't seem to be connected anywhere. It's not connected to the central lymphatic system. There is some perfusion of the duodenum, but it's not quite significant to explain the patient's clinical presentation. And there's also no leak into the ascites as well that we would sometimes see. But with the intrahepatic injection, we're actually able to opacify quite a bit more information. One, there's more perfusion of the duodenum. There's not really a clear leak either into the ascites of this patient, but when you see how the central thoracic duct is actually present and opacified, you can see that as it courses up here into the chest, that there is a significant deviation in the course that the duct is taking. And when we look at that back with the T2 imaging, we can see that this correlates really closely to where the lymphatic malformation is. And so we hypothesized that maybe this lymphatic malformation is actually causing compression of the lymphatic duct or the thoracic duct and actually leading to the patient's symptoms. And what we found with direct access to the thoracic duct, that was indeed the case. So in a very similar injection here with a catheter in the thoracic duct, we see that there's this area here of a little bit of stenosis. And when you measure the pressure there versus the pressure in the vein, which typically in the lymphatic duct, they should be pretty close to being equal within a couple of millimeters of mercury. In this case, there was a 15 millimeter gradient, which is quite significant in the lymphatic system. And together with our interventional radiology colleagues, draining this lymphatic malformation here while opacifying the central thoracic duct, you can see the almost immediate change in geometry that the thoracic duct takes with just removing that extra fluid from compressing the lymphatic duct. This also resulted in almost resolution of the gradient as well throughout the thoracic duct down to normal levels. And so these are all examples of where multi-compartment imaging has clearly affected our ability to both diagnose as well as changing our treatment strategies for patients who have systemic lymphatic diseases. And since more and more patients are actually presenting with more and more compartments involved, it's actually crucial, really crucial to our understanding to have multi-compartment imaging. And we're finding more and more that this turns out to be more of a global problem, despite what your current presentation is. And so with this idea that there's more of a global lymphatic problems, even in patients who may not have any overt clinical manifestations, it lends us to being able to create more precise diagnoses and phenotypes. And being able to take this new information that we have to be able to accurately diagnose and phenotype patients, there's a new field emerging called precision lymphology, which basically is able to take all these diagnostics that we're able to do and combine that with our genetics, with our increasing understanding of the genetics behind a lot of these diseases, and combining these two to help us be able to tailor therapies for patients that may not otherwise have been available, and actually can really help guide us in which options are the best for each patient individually. To illustrate that, I wanted to go through a couple of case examples with you where this process made a huge change in several of our patients' lives. The first one was a patient who was 12 years old who had a history of CCLA, or one of the conducting lymphatic anomalies, who had manifestations with fluid accumulating everywhere, essentially in his chest, in his abdomen, in his skin, and his extremities, causing severe lymphedema. And through our wonderful work by our genetics colleagues with Dr. Håkon was able to identify an ARAF mutation that through animal models was actually shown to cause maldevelopment of the lymphatic system that was actually partially reversible by the initiation of a MEK inhibitor. So this patient was actually given a sort of compassionate use to try this medication since he had no further options. And with treatment of MEK inhibition in his particular genetic pathway resulted in profound improvement. So his respiratory parameters, as I mentioned, he had significant pulmonary involvement, doubled. He had significant improvement in even his oxygenation, as well as his lung function. We also saw that there was a quite strikingly remodeling of his lymphatic system from this organized spider web of lymphatics that you can see on the left to more patterned lymphatics that actually allowed for better improvement and flow up through the central lymphatic system. And we saw significant improvement from a clinical standpoint in the terms of lymphedema. We actually saw very, very robust reduction in edema in his lower extremities. And when he initially had presented, he was quite sick and had a very sort of poor quality of life with an inability to sort of do his daily activities. And with this medication therapy and identification of these different genetic components, he was able to significantly improve his quality of life with quite striking improvement in all of his symptoms, and now having a much better quality of life. Another patient I wanted to mention was an 18-year-old that we had recently treated who had KLA, who also had similar involvement with the pulmonary lymphatics as we've seen before with KLA patients. Also had pleural effusions and was found to have a CBL mutation. And similarly was treated with a MEK inhibitor, which would inhibit overactivation of the MAP kinase signaling pathway. And she actually had quite striking improvement in her symptoms. Her pulmonary function almost completely normalized. The coagulopathy that's typically associated with KLA also completely normalized. The lymphatic system had some quite striking remodeling, which I'll show you pictures of in a second, but from a pulmonary parenchyma standpoint, one of the most striking features was the fact that the treatment of this disease with this medication resulted in an improvement in the pulmonary architecture as well as complete resolution of the effusions. Now, this correlates very well with what actually is changing in the lymphatic system, and it's actually modifying the structure of the lymphatic system. You can see overall it's still not normal. There's still a lot of dilation and tortuosity to the central thoracic duct, as you can see here, but you can see that there's a significant reduction in the amount of pulmonary perfusion that was actually underlying the cause of the patient's symptoms in abnormal pulmonary function tests. And then you can even see that on that T2 imaging that I had showed you previously, where you could see the mediastinal thickening and the pulmonary effusions, and that is almost completely normalized post-treatment with this medication. And so it has great abilities to really affect the disease process and actually try to change the course of these systemic lymphatic diseases to hopefully reduce the morbidity and mortality associated with them. And finally, with another example of precision lymphology is the third patient we had with Noonan syndrome. She had a SOS1 mutation and chylothorax, PLE, and an upper GI bleed. Again, this is very consistent with what we're seeing, and that there's multiple compartments that are involved in a lot of these systemic lymphatic diseases. She too was also treated with trametinib, again, to help decrease the MAP kinase signaling pathways. And with her symptomatology, again, has striking improvement. Her hemoglobin levels normalized. She no longer had any upper GI bleeds. Her albumin levels also normalized. there was significant remodeling of the central lymphatic system, just like we saw with the other two patients. While again, it's not completely normal, we see that there's quite a reduction in pulmonary perfusion, as well as a significant reduction in the intestinal perfusion that actually correlated exactly with what the intestinal mucosa looked like, with normalization from a very lymphangiectasia and very dilated and erythematous bowel to a normal bowel. So through precision lymphology, we've actually been able to start to understand how we can tailor treatments to our individual patients. And in summary of everything that I've sort of talked about, I know it's a lot of information, but lymphatic flow disorders, particularly as manifestations of the systemic lymphatic diseases, are quite serious and sometimes life-threatening. I hope I've impressed upon you that imaging is an absolute necessity and a very key first step in both diagnosing these individual diseases, as well as it's an adjunct to guide therapies that are available. And with our new lymphatic imaging techniques that we have, both from a liver lymphatic standpoint, as well as now the new mesenteric lymphatics, we're able to understand more components of diseases that we thought we understood before, but we're actually identifying that we don't know exactly everything that's occurring, and that this allows us to basically tailor new and innovative treatments to help patients who are struggling with these diseases. And finally, I hope that you've seen that precision lymphology and this precision medicine that era that we're entering is here. We are seeing some of the initial benefits in subsets of these patients, but it's quite clear that it's here to stay. And I think as time goes, there's a lot more research, there's a lot more that we need to understand, but there is some significant improvement that we can see, and I'm excited about what's to come. So with that, I'd just like to thank everybody for your attention. And now I guess I will start to look at some of the Q&A questions here. Let me see here, a few questions. Do we also treat adults with primary lymphatic disease? Yes, we do. We actually, while we are a pediatric an institution, we actually treat kids and adults actually of all ages, all the way up into their 40s and 50s. So we have quite a few series of patients that we're able to see. One of the questions from Karen is, what is the phenotype of hepatomesenteric flow of lymph? Can this cause abdominal obesity? That's a very interesting question. This hepatomesenteric flow pattern that we're seeing, we initially thought that it was going to correlate with ascites, such that with the edematous nature of causing more fluid to accumulate in the mesentery, that it would actually weep this extra fluid and actually cause ascites. In the cohort of patients that we have, we saw that trend, but it didn't ever actually reach statistical significance. I think it's a category that we don't entirely understand, but it's an interesting thought whether or not this retrograde flow can actually lead to changes in fat development, which we know can occur with chronic lymphedema. There's secondary changes to the dermal architecture that actually leads to basically increased fat deposition. So that's an interesting possibility. It's not something that we've actually looked at just yet. Another question came up with, could we describe the sort of intranodal lymphangiography technique? So the access techniques that we use in order to, let's see if I can scroll back here, access the various components of the lymphatic system is all a predominantly an ultrasound-based access technique, where we're able to see the lymphatic structures under ultrasound and actually, there we go, oops, insert small spinal needles, essentially, or small 25 gauge needles, about the size of an insulin needle or a Lovenox needle, into the lymphatic structures that we visualize by ultrasound. So initial access is actually under ultrasound, and we confirm the position of these needles, that they're in the correct locations, under contrast fluoroscopy in our cath lab. And here at the Children's Hospital of Philadelphia, we have an ability, or what we call an XMR suite, where the cath lab, or interventional suite, is directly adjacent to our MRI scanner, where once we have access, we're able to actually just rotate our table and slide right into the MRI scanner without having to move across the hallway or to other parts of the hospital in order to accomplish the imaging. So another question from Janet Friedman says that, well, you see mostly adults with lymphedema, and there are also some children that you see, but there may have one or more limbs involved. Should they all have imaging, even if no other medical issues are seemingly present? You know, that's a very interesting question. A lot of the diseases that we see are represented basically by the dysfunction of the lymphatic system in compartments that can cause increased morbidity and mortality. With lymphedema, it definitely has quite an impact on quality of life, as well as the ability to function, increased hospitalizations due to cellulitis and infections. So a lot of times we don't see a lot of patients with primary lymphedemas, but we have seen several that we can actually do the imaging on. And while there may not be any clinical signs of other manifestations of lymphatic failure, you can actually classify and help characterize where a lot of these problems could actually be arising from, especially with the lymphedema. And they can be associated with a lot of different syndromes. And again, as a big driving force for a lot of what we're seeing now is a multidisciplinary approach with precision medicine and precision lymphology to be able to help identify the underlying cause for these. We hope will help us be able to treat more and more of these patients. So another question from Purnima Patel: is it safe to treat these patients with upper and lower extremity edema, I presume, with central lymphatic dysfunction, with compression stockings or compression therapies? That is something that we actually do quite often. There are some instances where we would opt not to, particularly if there's any sort of abnormal leaks and other perfusions. But with treatments of our interventional techniques, we can actually identify or treat those, and then be able to institute some of these other more manual compression therapies that can actually help with their peripheral lymphedema. I want to thank everybody for your time and for your patience, and for listening to sort of what the new and innovative things that we have here at the Children's Hospital of Philadelphia. So I appreciate your time, and I thank you again for this wonderful opportunity.